And we're live. Well, we're on tape. Welcome to the show, John Chamberlain. It has been a long time that I've been wanting to have you on, and the stars aligned, and here you are. So welcome to the show.
Thank you very much, Hunter. It's very nice to see you in motion instead of a static picture. A little bit about me. I am a retired, or as I have said in the past, a recovering hospital CEO, and for about the last, and physician practice executive, and for about the last almost 10 years now, have been involved heavily in alternative forms of delivery and reimbursement mechanisms. My whole career, I've been a patient and physician advocate. It's been much easier since I'm not employed by our gargantuan health system to be able to do that. But again, 40 plus years in healthcare, and finally feeling like I'm actually contributing to something important besides my employer.
Besides your employer, yeah. Employers seem to be the ones that are causing some of the issues, but it's on the hospital side. You're also doing, you have is it a grassroots organization that you have?
I do. I've been involved with an organization called Citizen Health, and we've been at this for a little over 3 years now. And we are looking at a way basically to blow up the existing healthcare system in a positive sense by looking at reducing healthcare transactions to between the patient and the physician, utilizing various technologies, certainly blockchain, smart contracts, and really trying to take third parties out of the equation. That's a tall order, as you can well imagine, because that's where the money is made, and it's like making sausage. You don't really want to see it. But we feel that that's a way to advocate for patients and physicians. And one thing we have to remember is that we're all patients. If you're born in a hospital, you're a patient. If you're born at home, hopefully you won't be a patient ever. But the point is, we're all patients, and physicians are patients as well. So by virtue of my involvement with Citizen Health, we're also part of an organization called Free to Care. And that organization it's a coalition representing 30 different organizations, over 8 million individuals, and over 70,000 physicians. So both organizations are about what we've been talking about: patient advocacy, physician advocacy, and a way to really take another look at how healthcare should be provided and how it should be paid for.
Yeah. There seems to be, and I've had this conversation before with physicians, patients, and other experts in the field of healthcare. And when it comes to direct primary care, direct pay, which is essentially what you're getting rid of the middlemen, basically means going direct. And it just seems to me that I see the messaging going on, and I wanted to pick your brain for a moment and just, my perception is this, that you have a lot of different messaging points that are being made. I see doctors, DPC docs doing this. They talk about time with the patient or whatever, but there's got to be one thing that brings everyone together that resonates, because you do need one or two bullet points that just stick it, just there. Whether it's privacy, or I personally think privacy is probably the best bet, because everyone can agree that without privacy, we're sunk. In terms of doctors, what are they going to do? How are you going to trust your doctor if they're in a system that is essentially spying on the patient? Not a good thing. So I think with these bigger organizations that there's got to be something that reaches the public and really gets them at a gut level and say, wait a minute, That's something I need to know more about, and that's something I need to fight for. And when they fight for it, they've got to know where to fight, and that usually means Capitol Hill, making noise. I don't want this. And that's, to my mind, changed my mind, John. I mean, I'm open-minded enough. If you got enough people calling Capitol Hill and saying, "What the hell are you doing?" they're going to listen and say, "You know what, Mr. and Ms. Lobbyist, my voters are saying, I can't listen to you. I'm sorry, I can't take your money." The voters are looking at this and, sorry. I mean, that to my mind is I think the only way, other than outspending them, which, good luck, right? It's motivating the general public to say enough is enough, because we're going to lose X, or we need this, one or two things. And that, to my mind, is the critical issue. How to get the public talking in one message to Capitol Hill. Don't ruin my X. John changed my mind.
Well, I tend to agree with you, Hunter. In reality, to get wholesale change, that's what's going to happen. And we have a handful of legislators that are true champions for this cause, if you will, but they are in the minority politically, and also in the minority numerically. I think you hit upon a really important point. Until enough people, enough voters say, "I've had it, I'm fed up with this," that's probably not going to be an effective strategy. We have a few bills right now sitting in committee and have been sitting there over 2 or 3 different congressional sessions because there's no, if you will, willpower or power of the people to move them forward. They're not important. And the reason for that is that certainly since the Affordable Care Act, which is a misnomer, and really long before that, the people have been, I guess, and I'm a people too,
Well,
their minds have been taken away. Their decision making has been taken away. What I used to say, "I've got the card right here. I don't have to worry about taking care of myself. I've got insurance." And every day that goes by, insurance means nothing to people when they finally go to the doctor and they say, "Okay, how much, what do I owe?" "Well, you have a $40 copay." "What? And you haven't reached your deductible." "Well, what's my deductible?" Because, people really don't know. They just have not taken it upon themselves to see what the limitations of their, quote, insurance, I'll do quotes in air quotes, what their insurance covers or doesn't cover. And honestly, it really isn't insurance. Insurance, to my mind, is how do I cover unanticipated events? And why should I be paying horrendous premiums when I'm healthy? And even if I get the flu and I go to my doctor, I've got copay this, and this is not going to be covered. But people have been, I guess, hypnotized for years, for decades. I remember back in the 90s, we had true indemnity style, what I would say catastrophic insurance. You went to the doctor if you had to have a procedure to certain limits. You paid for that procedure, then the insurance company reimbursed you. That did a lot of things. That made it reasonably inexpensive. It also made you, take time to think about, do I really need this procedure? And at that time, you could, if you had a doctor you trusted, you could say, well, do I really need this procedure? Today, that's completely out the window. And I think, but we brought it upon ourselves. We have not said anything. Employer group plans are getting worse and worse and worse with narrow networks. The employer doesn't even have control. Who's in control today? Insurance companies and hospitals. The cartel, as we refer to them. And those decisions aren't even being made typically at a clinical level. They're being made at a business level. And I know because I worked on one of the areas I don't think I covered. I spent a couple of years working for Cigna HealthSpring, And I did that because if I'm going to badmouth them, I want to see if I'm being fair. Oh, I was fair. I was very fair. And I was a bad boy working for an insurance company because I would routinely give physicians approval to do procedures when they convinced me that it was appropriate and it wasn't just to put the down payment on a new Mercedes. I would routinely give them approval, and I'd beg for forgiveness later. Um, and what that did, it was again both patient and physician advocacy. Well, I saw enough in a couple of years. I said, I don't want to do this anymore. So I went back on the clinical side and tried to do it from a different standpoint. I worked for a couple of different urgent care companies, one strictly in urgent care, the other was a hospital that opened in urgent care. And I felt I could get closer to the patients that way. And I left that situation after several years for both companies because when I would, in this one setting, my most recent setting, patients would come in. They were coming to the Gulf Coast. I live in Alabama, and they were spending every last nickel they had to rent the condo, eat out, have a good time, and invariably somebody in the family would get stung by a stingray or have some issue. And we had a policy in place. It was $100 up front if you were uninsured, and see you later, which is pretty reasonable. $100 when you're spending your last dime on your vacation is a lot of money. But my employer shortly thereafter said, well, we're going to have to stop that because we did an x-ray on this person, we did an injection, blah, blah, blah. And you're going to have to bill them over the $100 before they leave. And I said, great, that's really helpful to the patient. And you give me an EMR that will allow me to do that before they leave and we'll talk. Well, that wasn't going to happen. So at any rate, I said, okay, I've had enough. And I left that, my last full employment. I was old enough to retire and I had it up to here. So that's kind of it in a nutshell.
Now you're a warrior, like me. So this is the other thing. You mentioned this, that there are 12 states that are doing something about direct primary care.
Right.
But so before we do a little dive into that, where do you think the most impact is going to be in terms of strategy, the public reaching out and saying enough? Is it Washington, D.C., or does it also have to be the state capital?
I think the state capital, again, you're talking about access, and access to your state legislators is typically easier than access to your federal legislators. I've had success at both levels, but the local reps, both senators and congressmen, if you will, state legislators, are usually more accessible. And having had that experience here in Alabama, helping formulate the direct primary care legislation and promoting it through the state legislature, they were receptive. I didn't really run into, we fully expected to run into the 800-pound gorilla known as Blue Cross Blue Shield of Alabama, and that they would put their foot down and say, we're not doing this, you're not doing this. And surprisingly, I think it's just that they thought we were like a gnat. We weren't going to injure them. And they're probably correct to this date. This was 4 or 5 years ago. But we have legislation in place. But I think, again, it's got to be at the state level. And how do you approach a state legislator? Okay, we've got DPC laws in place in Alabama. How am I going to reach out to them and say, look, we're not doing any kind of a demonstration project in this state. We haven't expanded Medicaid, and hopefully we won't, because all you got to do is look to our neighbors, to the next state over, not Mississippi, but Louisiana. Ask them how that's impacted their budget. And it's fine for the first year or two when the feds are picking up 90% of the cost of Medicaid expansion, but that doesn't last forever. So I think state and even local to some point is important. Again, it comes to ease of access. Ease of access is directly in proportional to power, if you will. But I think it's important. Healthcare is and always has been local, in my opinion. And yes, you have large hospital corporations and insurance companies, but when it comes down to it, it's between you and your physician, preferably. Unfortunately, we have all these interlopers. So
Yeah.
I think it's important on both levels, at the state and at the federal. And some states right now still don't have DPC legislation in place. And that varies. So you have to look at those points where you're likely to have some success, even if it's small. And that's how it works. You find success, you build on that success. And do I ever see this being a national DPC movement? Not in the typical fashion. I think what we need to do is provide a centralized information resource for all these, if you will, pure DPC doctors that aren't part of corporate DPC efforts. But I don't think that's important. The DPC relationship is between the physician and the patient, and the employer in those instances where the employer is providing, if you will, support funding for that employee to use a DPC practice. But yeah, I think it's got to happen. I don't see anything, honestly, don't see anything happening in the foreseeable future with the legislation that's sitting currently at the federal level. And that's unfortunate. The states, right. And primarily that, one of the big factors there is the HSAs. And the HSA is a federal novelty, if you will, and states don't have much control over that. So that's where I would see there would be some real value in having some kind of federal assistance in making HSAs available to people that are not employed. I'm on Medicare. I'm not employed. I can't have an HSA. Believe me, if I could, I would have a DPC doctor in a heartbeat. I'm trying to put them in this community. But I think that's an important federal look-see, if you will.
Well, you hit on an important subject, and that's how do you get HSAs and eligible DPC reimbursement. HSAs reimbursing for DPC. There was something on the agenda not that long ago that I think it was President Trump signed in. And I remember Lee Gross was standing next to him. There was something about that. Is that dead, or where is that?
Well, it's been folded into a piece of legislation called the Personal Care Act. And I think Ted Cruz and a couple of others have gotten behind that. And again, it's sitting in committee. This is in its second or third session of Congress. I don't think it's been tweaked much, but that HSA piece is in that legislation that looks at DPC and then also as HSAs being made more widely available to people that are not employed, making them even available as a funding mechanism for Medicaid to provide vouchers for each Medicaid beneficiary. But again, it's basically sitting in committee, and I don't see it getting any activity, certainly in this session, and as long as the current regime's in place.
Mm-hmm. We also have another little issue, and that's something that I've heard you mention this before about the corporate direct primary care companies who are, well, there are people taking the DPC concept, and I think you used the term diluting DPC. Can you elaborate a little on that?
Sure. There are regional corporate DPC companies, if you will. Some that come to mind, there were actually DPC companies prior to this current crop, if you will. Probably the most well-known is a company called Q-Liance out in Washington State. And they were very successful on a pure DPC model. They didn't have any third parties involved. They didn't have any outside financing involved. And they got to a point in their progression as a company that they needed more capital. So they went outside and got it, and that was their death knell. because all of a sudden it changed from patient benefit to ROI. And another one is Turntable Health in Las Vegas. That's Dr. Zubin Damania, Z-Dog. His company had the same issue. And this outside funding, whether it's private equity, predominantly private equity, is the death knell. So these companies that are extant right now, one that comes to mind is Iora. They focus on Medicare, but they're a hybrid. I think the doc behind that is a very well-intended doc. Again, they're falling prey to outside influence, outside investors. Even in a situation where they don't have that, you have a third party by means of an administrative hierarchy. It's no longer the doctor's sole decision, along with the patient, to decide how care is delivered. There's some kind of outside influence. Now, I know that's real kind of ideal namby-pamby that you don't have any outside influence. But in reality, the pure DPC docs that I know do quite well, and they don't have that outside influence. They are doing a great service to their patients and to themselves, not only from a lifestyle situation, but also from a remuneration standpoint. They're doing fine. Most of them I know that are pure DPC are making as much, if not more, salary-wise than they would if they were employed. And they don't have all the headaches, and they don't have somebody looking over their shoulder in a coat and tie telling them how to practice medicine.
Their quality of life is much higher.
Yeah, the fear that so many new residents coming out of residency, new doctors coming out of residency have is medical school debt. Hey, understandable. And, is that part of the game? Capping residencies for the last 24 years, not making residencies available. Here's kids, if you will. I'm old enough, I can call them kids, coming out of, medical school with a couple $100,000 worth of debt, and they can't even get a residency. How are they going to make a living? There's some things going on right now that are taking a look at that, making them eligible. Some states have legislation in place where they can work as an assistant physician, per se, work in settings where they can actually generate some income instead of flipping burgers or waiting tables or what have you. But the reality is and I don't want to get off down this rabbit trail necessarily, but there's a lot of competition right now, legislated competition by all these states that are looking at full practice authority for, I know my nurse practitioner friends hate the term mid-level, but that's what they are compared to a physician. But I think, again, any outside influence on a DPC practice is, in my mind, makes it a hybrid or it's diluted. The concentration needs to be between the patient and the physician. The patient needs to have trust in the physician, and the physician needs to do their best to provide the best care, counseling, comfort, whatever you want to call it, to that patient. For that reason, that's why DPC panels are so typically small. Mm-hmm. Are there enough primary cares to have everybody in DPC? No, there aren't. That's one reason it hasn't grown like you would expect it to. But I think the primary reason is lack of knowledge, both on knowledge of students that are in residencies or preparing for residency and know that there are options like direct primary care, and probably equally bad is the lack of knowledge about alternatives on the patient side as well as the employer side. There are a few enlightened employers that are making it optional to their employees to have DPC. And again, we touched on Medicaid vouchers a little bit. Just kind of look at this model. If you provide a Medicaid family, let's say of four, $200 a month voucher for DPC, and should they have need for further, diagnostics or what have you, then that's taken up in a different fashion and covered under perhaps, traditional Medicaid. But if you could imagine those folks having access to a doctor 24/7, or their children having access to a doctor 24/7, how many problems you could head off at the pass with that kind of primary care. So all this yeah about, well, what do I do if I have a heart attack? Well, how about you not have the heart attack in the
In the
first
first
place?
place.
Um,
What a
but
thought.
that's how insurance companies have sold this whole game of theirs. We protect you if something, no, you don't, because you don't do anything to keep me from having that event happen. And you give me a 7-minute office visit with a primary care doctor, I barely get signed in, and he sticks his hand out for payment, and I'm out the door. Um, it's bass backwards.
Yeah.
All the focus
What,
is on where the money is.
follow the money too. Where should someone go if they want more information and become more learned in this? Your organization. Do you have a link that we can show in the description of the show and perhaps on the screen?
I would think that, certainly coming to citizenhealth.io, we can certainly direct folks. There are a number of DPC related organizations, and I'm proud to tell you who they are because we all work together. We all have a common goal, which is something I can't say for uh, the intermediaries. Well, they do have a common goal, is taking your money. But I think dpcalliance.org is a very good, strong organization. There's a very good organization too, dpcfrontier.com, which is run by a DPC doctor and an attorney. He is both an MD and a JD, and there you find locations for direct primary care practices nationwide. Now, neither one of those organizations is 100%. I wouldn't say they're inaccurate, but things are changing all the time. So I would suggest people go to both sites, take a look. If you're interested in the model itself, it's pretty simple. Pay a monthly fee, get all the services that a primary care physician offers in their office for that set fee. You have 24/7 access. If you need diagnostics, whether it's imaging, CT, MRI, or lab work, or even outpatient surgery, that doctor that you have a relationship with is going to know exactly where to send you. And if you need a specialist, they're going to have an arrangement with a specialist. Typically, they're specialists that accept cash, so you're not bound by any insurance narrow networks or what have you. So again, the model itself is growing. You and I both know some folks that have been at it for a good while and are successful. And they're typically the doctors that don't care about explosive growth. They care about their patients. They care about having a life outside of the office. And now the one of the big COVID related things of the day is telemedicine. Well, guess what? DPC docs have been doing telemedicine for a long time, and
Since the day they opened.
digital health platform. Hey, I got news for you.
We all have
That's a
one.
digital health platform. Okay, who
Yeah.
doesn't have one of those? And
Hmm.
I mean, typically, not to be sassy, but most Medicaid recipients have cell phones. So, you don't need a fancy schmancy digital health platform. Um, but again, I think you've hit upon probably one of the biggest issues, and that's how do we communicate? What's the communication strategy to get employers, employees, Medicare beneficiaries, Medicaid beneficiaries, doctors for that matter? How do we get this word out that there is an alternative and it's much less expensive and you're going to get better care?
I would say I'll share this final thought with you about how to get the message out. And I learned this a long time ago. If you want to stop people from thinking about whatever it is they're thinking about, ask them a question. It
Right.
forces them to go, oh, I got to answer this. It's human nature.
Sure.
So we have to find the right questions, one or two questions that they go, ooh, ooh, wait a minute. Hold the phone. I want, I think I better call someone about this and complain. This is not good. So as you make the rounds, as you go within your circle of influence with these groups, I think that's the strategy. Come up with one or two things. That's from my perspective down here. Because in Panama, I'm sort of, I have a great underbelly view,
Right.
but bird's eye view. I'm not in the middle of it. I'm
Right.
looking at the forest. As an
Right.
American, I grew up in Chicago, so I care very deeply about what happens, and I see the solution. We see the solution. Otherwise, we wouldn't be doing what we do.
Right.
And that to me is the critical issue, that if we can make this next jump, and whatever that is, hammer that one. Everyone hammer that one all the time, 24/7. Boom, boom, boom.
Well, of course, what we're seeing now in the States, and you're well aware, is especially the de rigueur advertising of the day is ramming COVID vaccine down everybody's throat. All the celebs are doing it. All the ads are doing it. All the PSAs. Have you had the vaccine? You need to get the vaccine because LeBron James says you need to get the vaccine. We need a voice, not his necessarily, uh, the same kind of message. Unfortunately, that's who people listen to. They don't listen to friends and relatives as much, and I can't say that for everybody, but
Let alone a doctor,
yeah,
because they don't have a
goodness gracious,
relationship.
those
Yeah.
money grubbing guys and gals. Well, see, that's another lie that's foisted upon all of us here in the States. But no, I think you're right. And the question should be, are you happy with the health care you have right now? And if not, why? And you're gonna get varying responses. And then, another question would be, how would you like to have health care that you're happy with? Not just access, not just coverage, but actual one-on-one conversations with your physician. How much happier would you be for yourself at $75 a month or your family at $150 a month? Think about that. You can pick up your phone and text that doctor or however their preferred method of communication is 24/7. You get answers. You don't have to drag your rear end out of bed. You talk to them. Hopefully you're not dragging them out of bed, but you get an answer and you go pick up a prescription if that's what's called for. So, it will take obviously more refinement than that, but I think you've hit upon it. Give them a question that they have to ponder. Another question would be, how much are you currently paying for insurance? And what value are you getting out of that insurance? When was the last time you saw a doctor? When was the last time you met your deductible? Do you even know what your deductible is? Most people don't, and they are shocked and surprised when they have a copay and or end up paying the whole thing.
Well, John Chamberlain, thank you so much for joining me today. It's been a pleasure to see you.
Same here, Hunter.
Really
Finally.
yeah, finally, and I appreciate the insights, and I hope people will go to your website and the others mentioned, so they get a better idea of what's going on.
Great.
For Winning Healthcare Food Fights, I'm Hunter Schultz. Stay healthy, wash your hands a lot, and there you are.